much. It's really a privilege to be here with you today. I'm very excited about the conference and about talking about from birth to death and everything in between, tackling sex and gender and women's health across the lifespan. And I thought we'd start off by trying to be a little interactive. So I want you to take a moment to share in the chat, which you'll see on your computer screen, why are you here and what would you like to learn today? So please, I invite you to write in the chat, why are you here and what would you like to learn? And while I see the answers are going to be starting to come in, let me tell you why I'm here. I'm here because I had the fortune of being mentored by Elizabeth Barrett-Connor. I already had an interest in women's health. I noticed from the first time I worked in the coronary care unit that they treated men and women differently. Men went straight to the cath lab. Women in those days got hormone replacement treatment if they had a heart attack. And I said, well, that's good, we're treating them differently, but is it really evidence-based? And so I dedicate my talk today to Dr. Barrett-Connor, a real pioneer in women's health research who told me to look at the raw data, always disaggregate, and seek the truth. And so what I'm going to invite you to do with me today is to reflect on the truth behind the multiple dimensions of sex, gender, and intersectionality from a woman's lived perspective. I'm going to invite you to reflect on the importance of sex and gender in girls' and women's health research across the lifespan, and also what actions we can take to shape the future of women's health. Now, I'm going into this talk with some assumptions. I know that you are a very savvy audience. I know that we have students, we have master's students, graduate students, undergraduate students, maybe some residents, faculty, diverse faculty. We have highly qualified research personnel. And so I'm going to assume that you know that the terms sex and gender are not interchangeable. If you agree, please write in the chat box that you agree that the terms sex and gender are not interchangeable. And of course they're not, because sex represents biological attributes of humans and animals, including physical features, chromosomes, gene expression, hormones, and anatomy. And we use the term gender when we're referring to socially constructed roles, behaviors, expressions, and identities of girls, women, boys, men, and gender diverse people. And when we talk about biological sex, a lot of people think that it just applies to genes. We know that everyone has 22 identical pairs of chromosomes and one sex chromosome. Now the X chromosome has 1,669 gene, and the smaller Y chromosome has 226 genes. This, of course, leads to many different expressions and characteristics, but what people don't know sometimes is that the autosomes, those other 22 chromosomes that aren't the sex chromosomes, are equally, if not more important players that contribute to sex-biased gene expression. And some recent papers have shown that 85 to 90% of genes exhibiting sex bias in humans are actually autosomal. So if you assume that sex differences were due to the sex chromosomes, think again. Sex even influences protein structure. Sometimes people say at CIHR, well, when do I not have to include sex? When is it justified not to think about sex? And I used to say, well, maybe if you're studying proteins or you're studying something outside of humans, but we've since learned that actually sex can explain 13% of differences in what we call protein complex abundances in stoichiometry, which, believe it or not, is how often a protein is expressed and even what its 3D structure is. So sex is more important than you might have thought. Second, I'm going to assume that you're aware that gender has multiple dimensions. So if you talk about gender, I'm gonna, if we were actually sitting together and you started telling me about your research and you told me that gender applied, I would say, well, which dimension of gender does your research target? Does it target gender identity, which we define as an inner sense of self, as masculine, feminine, both, or neither, depending on the time of day? Cisgender, which is, does the sex that you were assigned at birth match your current gender identity? Transgender if it doesn't, or gender nonconforming. Would you tell me that you're interested in gender roles, which are societal expectations, such as the assumption that women will disproportionately be caregivers? But even within sex-specific research, women have roles. They might have their own personal role as a sister, a daughter, a mother, a partner, a spouse, a friend. And these roles are what shape us and play a large part in our psychological wellness. The career you pursue. You might tell me that you work on gender relations, which are interpersonal interactions in the family and the workplace, or that institutionalized gender is what you're interested in. And this, of course, has to do with the distribution of power in society, how social norms are shaped. I always think, when I think of institutionalized gender, about body image and seeing skinny women on the fronts of magazines, and who actually dictates that, you know, that's better than real women having curves, like most of us probably do. Now, I'm also going to assume that you know that these concepts don't stand alone. So when we talk about sex, and here I've written it out for you again, we talk about gender, they are not necessarily completely unlinked. They are intricately intertwined. And even more, you can't take them away from other identity characteristics, which is where the term intersectionality comes from. Intersectionality was actually coined by Kim Crenshaw, a Black feminist scholar and activist, who said that it's really about the voices of who we are and power imbalances in those voices being heard because of the intersections of being a woman and being Black, or because of my sexual orientation, which very different than gender identity, right? Sexual orientation, if a woman's a lesbian or bi, you know, who she's attracted to, not the same as how she feels in terms of her masculinity and femininity. So keep these concepts in mind, because my third assumption is that most people have simple views of women's health. They either say, oh, you're working on women's health? Oh, you must be working on sex-specific topics, like, you know, the body parts approach. Maybe you're working on pregnancy. Of course, only women have a uterus, or ovarian cancer, because only women have ovaries. Or women's health research, oh, you mean the sex difference part of women's health research, the fact that 3 times more women than men are more likely to be diagnosed with depression, or up to 9 times more will suffer from autoimmune diseases, or 3 times more are living with Alzheimer's disease. Is that the kind of women's health research that you're doing? And yet, I would posit that there's a lot more to it than, is it sex specific or is there a sex difference? In women's health research, we have to start asking, could a sex difference be explained by gender or by a gender variable? And so I want you to start using the terms gender variables when you talk about women's health research. And of course, just like I told you before, it's not enough to say I'm accounting for gender. If you haven't already, in the chat box, write what type of, you know, what dimension of gender you're working on and how you might collect variables on that type of gender. So if we talk about roles, would you be measuring housework responsibilities in your research, childcare responsibilities, caregiving responsibilities? Really need to break it down if we're going to dissect, better understand, and better deliver on our goals for women's health research. And if you're not exactly sure how to collect gender variables and how to apply them in your analysis, here's a little heads up on methods for prospectively incorporating gender into health sciences research. We have a lot of tools, but this is one that just came out recently, and I would invite you to check it out. The main crux of my talk to you today is to argue that it's time for a paradigm shift in women's health. And that's what I meant when I said that we can no longer use women's health and appreciate women's health from a simplistic point of view. I feel very strongly that it's a moment in our history to go from dichotomous thinking about male, female, to non-binary thinking, where if you take the sex hormones, for instance, both men and women at different points in their lifespan will have estrogens, will have testosterones, and the distributions won't necessarily be independent of each other. But even past this idea of non-binary in women's health, I would challenge you to think about spectrum thinking, so that sex isn't, again, male-female, but that there's an intersection of intersex in between, and that gender identity also isn't woman, man, or gender expression, feminine, masculine, but that these concepts truly exist on a spectrum. And where I'm hoping we'll land at the end of our talk today is that women's health is really about identity. And so if you look at this, the beginning part of my slide where we started women's health historically with sex-specific body part research, or bikini medicine, if you will, covering the parts of the anatomy that men don't have, and maybe thinking that we've moved towards sex and gender science, and that's probably where we were last year or the year before, where we appreciate that the biological and the social needs to intersect, to where we are today with the entire Black Lives Matters movement and BIPOC, and how important intersectionality is to women, to where I believe we need to be, which is a reflection of women's multiple, special, different identities, and recognition of a woman's identity and how she interacts with the world beyond her body parts, beyond sex and gender, beyond all her other intersections, to who is it? Who is that woman that we're treating, is where I believe our thinking needs to go. So let's start, because if we don't, we're going to end up with a lot of real life confusion. And many of you will recognize Caster Semenya and Dudi Chand, two medal winning marathon runners, and who have come under scrutiny in 2018 when the International Athletic Association said, well, are these women really women, and are they eligible to be running in the female classification for sports? Because of intersex, probably genetic composition and androgen sensitivity, the whole concept of what is a woman and how do we classify her came into play. And so if we don't start considering women as identities, then we're going to continue having this confusion, which leads to a lot of, I would say, possibly unfairness and not very progressive ways of thinking about the world. So the importance of sex, gender, and intersectionality across a woman's lifespan. It starts before birth. I mean, even before children are born, we could see differences anatomically in fetal and infant growth patterns for female or males in utero. But even while they're still in utero, gender assigned by parents, if you know the sex of your child, may already be having an effect. Do you play different music for your baby if you know if it's going to be a boy or a girl? Do you start decorating the room differently? Do you start buying different clothes? And so sex, gender, and girls' and women's health, I would argue, definitely starts before birth. They say a picture paints 1,000 words. Here, as you can see, a lot of the gender expectations based on your sex continue early in childhood and help shape your earliest childhood memories and your identities and what's expected of you. And this, I'm going to come right out and say it, this gender bias has an effect on diagnosis. And you probably didn't think that I was going to talk about autism today, because autism is typically thought about as being more common in boys and being more important in boys. It is 4 times more common in boys. But because of the gendered expectations that we put on girls when they're young, that it's, okay for them to be passive, that it's okay for them to be unusually sensitive, that it's okay for them to maybe not talk and let others speak up for them, we are less likely to be diagnosing autistic symptoms in girls, and consequently, treating later on in life. And so this gender bias comes in really early and continues throughout life based on the way that we're shaped from infancy. Of course, gender identity plays a role. you've heard the term tomboys for girls. You could be a tomboy, and is that accepted? I do think it's more accepted now, and of course I think that we're more open. But gender dysphoria, when you're not satisfied inside with the gender expectations that your parents and society has on you, can lead to, even at a very early age, people questioning whether the sex they were assigned at birth really matches their gender identity. And this is something, when we look at girls' health, that we need to be more and more cognizant about, because it is associated with mental health problems later in life, with stigma, with discrimination, with suicide, and with the sense of confidence in who you are, which at the end of the day is really about what gives women well-being, feeling good about who I am, what I show to the world, and what I deliver. And of course, this continues into adolescence and young adulthood, where sex-specific changes become more apparent. Think of how alone some girls feel when they first have reach menarche or have their first period. A lot of them, it hasn't been explained to properly. Menstruation, in many areas of the world, menstruation is seriously stigmatized. Here you see a sign saying women are not allowed to enter the temple during menstruation. So what kind of effect does that have on women's psychological well-being, where the sex interacts with the gender? And of course, this idea of women having to be responsible for their health. Here we have a picture of human papilloma virus associated cancers. Well, transmission is usually a partnership. But here women have to go for their pap smears, and it becomes their responsibility to get the vaccine, although of course we've been encouraging boys to get it too. But just the sex really does affect some of our actions, how we interact with our health, and again, what that means to us as an individual. Because contraception also then lands as a woman's job, because she is the one that gets pregnant. And never mind, maybe more research being needed in different contraceptive options, and there being no male pill yet. Yes, you can have vasectomies for men, but that usually happens later in life. What kind of stress do women go through? How many women have said, well, maybe I'll try an IUD, but then it doesn't work and it's painful, or maybe I should take pills, the oral contraceptive pill. My own personal story is that I was having some breakthrough bleeding at one point, and my gynecologist said, try this new one that just came out on the market. It was called Yasmin. And fast forward, many of you know that there's a class action lawsuit against Yasmin, because sure enough, it gave me a deep vein thrombosis and a pulmonary embolus. And I almost died, because it was my responsibility to be using oral contraceptives if I wanted to. And so because of that, just women more at risk because of their anatomy. And what does that mean? And I'm fine, by the way, thank goodness, but the whole thing was very scary. And of course, it's affected my life and things that I do and the medication that I have to take because of that. I couldn't give this talk without mentioning endometriosis, which is a poorly understood disease that is often dismissed as just period pain by physicians. Not a lot of research being done on endometriosis, and the average time to diagnosis is 10 years after menarche, once, as the picture shows, women start suffering because of this. Now, we could talk about body parts, but I'd be remiss in not mentioning what we call metabolism for women. And so, of course, as you imagine yourself in your early years and imagine the days when we used to go out to bars, now I don't think anyone's doing that, at least here in Montreal where I am, we're not doing that anymore because of COVID. But even the way women process alcohol is differently, so that the allowable standards or recommended standards for safe drinking are different for men and women. Well, what kind of disadvantage does that put them if they want to win a drinking contest, or if they want to show that they're just as tough, or that, oh, sorry, I'm at the drinking contest because, I don't want to go past my safe limit. That's great. But because of our anatomy, again, this just speaks to women's wellness, women's health, women's perceptions, and how they're perceived in the world. Pregnancy is, probably the best and the worst part of a woman's life. It's the best part because we're privileged to be able to give birth to children, But I would say it's the worst part, because think of all the stress and anxiety that we go through, number one, in getting pregnant. About 15% of women struggle with infertility. So many have miscarriages or ectopic pregnancies. And then, once you give birth, you could have, I don't know if anyone's ever had a breast infection or other problems during pregnancy, urinary tract infections, even just trying to get a good night's sleep while you're pregnant. This is a critical point in a woman's life where sometimes a woman can feel very alone. In our society today, we don't grow up in the village where all the women talk about, what they went through with pregnancy, even the decision, if you're going to give birth, what kind of delivery, and whether you should get an epidural or whether you should do it naturally. There's so much stress on women, happiness too, but stress too, when they go through pregnancy, that we could do better, I think, in our research to support women through these sometimes difficult but exciting times. And of course, here I've put a picture of a Chinese woman crying. It didn't have to be a Chinese woman. It could be an Indian woman. It could be a white woman, because now that we're able to select what sex, and here I just put an ad up, and of course it said prenatal gender, but it's prenatal sex testing, a lot of emotional toll on, boys still being, I think, generally more valued in society than girls, and the stress that a woman has to be able to deliver the right, literally deliver the right baby for her family, and what kind of relationship and interaction that has with a spouse, not only trying to get pregnant, especially if there are issues of infertility, but the decision and the expectation. And I just think this is something that maybe we don't talk about as much. We certainly study pregnancy in terms of looking at the embryo and looking at a lot of the anatomical things, but the idea of a woman's identity and her guilt and her sense of responsibility and who I am as a person, what I contribute, is to me where I believe we should be going with, if you will, more identity management in women's health research. Now, pregnancy has long-lasting effects. Many of you probably don't know that sometimes the Y chromosomes left over from a pregnancy with a male fetus can persist in both a woman's brain and other organs throughout her life. We call this fetal-microchimerism. And we just don't know if this DNA may benefit the mother's health or cause adverse effects. And this is somewhere where more research is being done and more research is needed. Motherhood. Well, motherhood, again, the most humbling experience in my life. I have 4 children and so many expectations of what I thought a good mother would be, until someone pointed out to me that being a good mother is recognizing what your children need and maybe not what you need. And it's this, struggle that I think we have that sometimes leads 1 in 5 women to experience postnatal depression. I have one memory of, I think it was with my second son, I think I was breastfeeding. I was trying to toilet train the first one. The doorbell was ringing. My phone, I had to answer my phone, and it was just like, I was alone. I'm not sure I had my shower that day, never mind brush my teeth. I mean, this is a very, can be a very trying time for women. Although, of course, the postnatal period trains us for the rest of our life as a mother, because what we hear, especially from women in STEM, if you will, so sciences, technology, engineering, medicine, is that balancing work and home life is challenging and definitely has its effects on women's health. Many of you may have seen Gretchen Goldman's post, I think it was about a month ago, where she was being interviewed on TV. She had just gotten a promotion as a climate change expert in the United States, and someone took a picture of her while she was doing the interview. This, of course, is during COVID, where women really do find that the tension between their different identities, between being a mom, being a daughter, being a spouse, being a scientist, working, taking care of the home, making sure it's clean, all these things that we juggle. How does that affect our sense of success or failure. It shouldn't, of course. Good enough is good enough, but these expectations that we have on ourselves, especially as high achievers, is really part of our everyday interaction with life and what constitutes a woman's identity. Intimate partner violence is an absolutely terrible thing. I'll take this moment to recognize Indigenous missing and murdered women. As you could see from the, the graph here, Indigenous women are at the greatest risk of family, domestic, and sexual violence. Many other groups are at risk. There have been large investments, but at the end of the day, I think that it's up to us to create the support for these women. I know that there's been a lot of apps for reporting, and I just heard recently that obviously in COVID, like, you even have the privacy in your home to report something if the person is living in the house who's committed the violent acts against you. And so lots to be done here in order to really emancipate and free women from the violence that's been put on them. Midlife cancers. Well, unfortunately, because of our body parts, women are more susceptible to ovarian cancer, cervical cancer, uterine cancer, vaginal cancers, vulvar cancers. Women are 10 times more likely than males to develop breast cancer. And a little shout out for women not being all the same. Lesbian and bisexual women experience cancer very differently, actually, than other women, as do trans women. And so the experience of cancer and not being treated as a cancer when women seek healthcare is extremely important. We talk about cancer survivorship. We talk about what it's like for a woman to lose her hair when she goes through chemotherapy. How many of us spend every morning, playing with our hair, putting it this way, putting it that way. And then the thought of losing your hair is part of your identity, especially for women, because possibly of the beauty aspect, that institutionalized gender that's put on women. Anyone here gone through menopause or know anyone who gone through menopause? It's just the hottest time of your life. Those hot flashes in the middle of a work meeting, waking you up at night, not getting your sleep. When you don't have sleep, you get more irritable, the night sweats. All these are very difficult, I think, for women to live through. And again, it also marks a time in your life where you say, oh, I can't have children anymore. And what's the second half of my life going to look like? 50% of women find it difficult to cope with work during menopause. Menopause is something that we're trying to normalize in society. What women want in 2020 is to be able to talk about this, to not have to cover it up as if it's a stigma. Women unfortunately cover up literally a lot, and we suck it up, and we live with a lot of things that I think that if there were more of a sisterhood, more support for women to be talking to each other, we connect over our vulnerabilities, we connect over shared experiences, and this is just one more that I think women really do need to connect to, and that more research is needed. I was asked to speak a little bit about my own research. I started off as a women's health researcher, as I mentioned, from the moment in my training where I noticed that women and men were treated differently. And I was invited to conduct a survey when I wanted to start a women's health center. So going back about 30 years now, I thought it would be wonderful if McGill University, where I was training, had a women's health center. And someone prompted me to say, well, you think you know what women want throughout their lifespan, but have you asked them? And so I went and I conducted a survey. I surveyed 5,000 women across Canada and asked them what their priorities for healthy aging were and if those priorities were being met. And what's interesting, I'm not going to go through the whole study, but if you just follow the lines, you'll see, for instance, that women in their 50s, the survey started at age 55, were very concerned about breast cancer because, of course, that was the age where they were seeing their friends and their peers and their family members start to get breast cancer. Sometimes it's earlier, but mostly the peak incidence is in that age range. And that decreased with age. Whereas if you go to the other graph, on the right side of the screen, you see that social services become more important, or getting a vaccine. Hopefully older women are going to be getting the COVID vaccine as soon as it comes out. But you know, I think that social isolation becomes more important, and some of the work that I've done when you've looked at quality of life really does have to do with a woman's purpose and you know, being needed by other people. Things that I don't think we talk about as much maybe as we should in our research on older age. When we talk about women at end of life, there's tons of investment in Alzheimer's disease, as well there should be, because we haven't found a cure, and we even focus on women caregivers. But do we focus on our meaning and our purpose in life, and the support that we get is something that I would challenge you on. And in this research, something came out that was really fascinating, I think, and that has led me to make the recommendations that I'm making to you today, is when we asked women what they wanted from women's healthcare, they indicated that they wanted to be seen as a whole person and not just body parts. And this, of course, is true because we send women to specialist care. You know, they're going to the OBGYN to, I don't know, have their PAP or their gynecologic exam. So then I'm just what's below the belt. You know, or we send women for heart rhythm disturbances, they go see the cardiologist. But very rarely, hopefully at least in primary care, are women seen as who they are, as a mother, as a working mother, as a sister, as a partner, as a friend. And this they find to be the most invalidating out of everything when this is not done within the healthcare system. Older women, women over the age of 65, what's normal and what isn't normal? Is it normal for a woman to have involuntary urine loss? 1 in 2 women over the age of 65 actually, you know, loses urine if they cough, laugh, sneeze, if they get an urgency and they can't make it to the bathroom in time. And very, very sadly, what I learned from my research is that almost half of women think that losing urine is just a normal part of aging. I mean, you never see 2 guys in a bar laughing and saying, "Oh, you're making me laugh so hard, please stop or I'll wet my pants." You ever see 2 guys say that? No, but women say it all the time, "Stop, you know, I'll wet my pants." And so I think it's important to recognize that you know, because women leak, we even talk about the leaky pipeline in progression, in career progression, which a lot of women have taken offense at, because the idea that women can be leaky, I think, is something that maybe we shouldn't be accepting. On the one hand, for menstruation, maybe it's normal, but certainly not for urine. So how do we address this? Is continence care offered to women? Anyone ever done a Kegel exercise? Do you even know what a Kegel exercise is? You could write it in the chat box if you've done Kegel exercises, but essentially it's contracting the pelvic floor muscles. By the way, the geishas in Japan, this was one of their tricks. This was, you know, contracting your pelvic floor muscles was really something that people valued for women. Now I think we have to really revive that. Unfortunately, many women get sent for surgery. Some research that I did was to try to get community organizations, so really developing community research to support women in conservative treatments for urine loss, because urine loss can lead to social isolation, stigma, and I think just the perception of yourself as getting older and losing some of your vim and vigor because of it. And of course, many of you will remember the Implant files, a big investigative series done by CBC, which investigated urinary mesh and breast implants for women. Medical products for women maybe don't have the same research rigor as they should. The urinary meshes, which were put in transvaginal tape surgeries to lift up your bladder if you're leaking urine, actually found to cause many side effects, and this is being investigated. There was even a scientific advisory committee on health products for women that was established to look at the way policy and regulation approves devices and medication for women. Right now, you've probably heard a lot about the inclusion of women in clinical trials when developing new drug therapies. Certainly when we talk about the vaccines for COVID, everyone's asking, are the people in the trials recommending, are they representing me? Are they representing my mother, who I want to give the vaccine to, or my aunt? You know, have we included women in a proportionately representative fashion in drug development? Probably not, and certainly not in medical device development. These meshes, if you can imagine, were they developed and tested in cell culture, but did they look at the difference between female cells and male cells? And is that why we're seeing more adverse effects with them? Because from the beginning of the research product pipeline, we talk about, you know, what if you're doing animal research or cell research, please look at the sex of the cell, compare the sex of the animals, you know, develop these products and test them in a hormonal milieu that represents women, possibly, you know, on different therapies, maybe for breast cancer. They might be taking anti-estrogens, they might be taking tamoxifen, they might be taking other hormone products, and all this needs to be tested, and it happens at the regulatory level, and the government now is paying some attention to that more than it used to, because women do process drugs differently than men. Sadly, we have more body fat than men, which means that drugs that accumulate in our body fat tend to linger. And also our liver might metabolize drugs differently. I talked to you a little bit about alcohol. One of the reasons why women can't handle as much alcohol is because of alcohol dehydrogenase enzyme, other enzymes in our liver. If you take certain oral contraceptives, it could have drug-drug interactions because of the way it expresses hormones in your liver, enzymes in your liver. Women's kidneys tend to be smaller, so they excrete drugs slower. And of course, our heart rhythms are different. You've heard of probably long QT intervals. Women on the cardiogram have a longer repolarization period, and this makes them more susceptible to arrhythmias or heart disturbances, and drugs have been withdrawn from the market. In fact, women are twice as likely as men to report adverse drug events, possibly because these drugs were not studied as much when they came through the drug pipeline for women. And an audit was done in the United States where they pulled 10 drugs off the market, and 8 of them actually were found to pose more of a threat for women. Many of them, like Seldane, it was an allergy medication that many of you are familiar with, because it caused torsade de pointe and sudden death in women, and other medication because of gender. Some of them were the appetite suppressant drugs, which of course women were more likely to take, even though biologically it was the same, but only women took them and had valvular heart disease because of those medications. We have a law in Canada called Vanessa's Law, which is reminiscent of Vanessa, a woman who died from a medication that wasn't tested in adults under 18. So age is important, and also wasn't tested in women. And now, thanks to Vanessa, we have more attention being given to adverse drug reporting in Canada for women. And of course, I can't just tell you, oh yeah, too bad, women have more side effects than men, because what are we going to do about it? And we have started doing some things. There's more than one drug that now has sex-specific dosing. Nocturna, which is a medication for too frequent urination at night, has different doses. Here I've put up Zolpidem or Ambien. Anyone know what kind of medication this is? You could type it in the chat if you want. I can't tell if it says. Well, Ambien or Zolpidem is actually a sleeping pill. Now, or an anti-anxiety drug. The anti-anxiety drugs and the sleeping pills kind of work the same way in the brain. And of course, are you surprised that 70% of sedative drug users, so again, for anti-anxiety or for sleeping, are women? Many of them are older. You may know that I'm a big deprescribing champion, because use of sleeping pills in older women, especially when they take the same doses that they took, which were probably too high for them, you saw on the previous slide that we're recommending half doses for women, cause falls, memory impairments, automobile accidents, and fractures. And you might say, so why do women take so many sleeping pills? Is it because of menopause when they couldn't sleep? Maybe, but if you speak to your medical historians or your anthropologists, you would actually find, if you went back in the 1960s, that there were ads for women to take tranquilizers, as they called them back then. So look at this ad. You can't set her free. She's chained in by her housework, and she has to be the perfect wife. You know, she has to welcome her husband at the door, being calm, cool, and collected. So this little mother's helper will help you take care of the kids and get the meal on the table and look, I don't know, all coiffed at the same time. So again, this is a time and a place where gender played a role in women taking more sedative hypnotics. In fact, did any of you know that the Rolling Stones wrote a song called Mother's Little Helper? And I'll let you read the lyrics yourself, but they essentially predicted the sedative and I think the opioid epidemic that we're going through today. I mean, women take a lot of opioids, both prescription, but non-prescription too. And why do they take them? I mean, that's a complicated question, and we're not going to talk about opioids today, but if you have any thoughts about why women, you know, have so much opioid use disorder, please write it in the chat. Maybe some of you are experts at this, and we could certainly talk about even the idea of a woman's hormone levels making the receptors in their brain more, you know, have a greater affinity for some of these medications. But at the end of the day, it's about identity. I think opioids, you know, take away your pain, not only your physical pain, but your psychic pain, your guilt, your disappointment in yourself. You know, it takes away the edge of trying to live up to everything that you want to be, and you know, what maybe your parents expect you to be, or the people around you who expect you to be. And so again, the risk of sounding repetitive, I think that a lot of women's health issues are truly about identity management. So I'll take a little pause because I'm going to jump right into the last part of my talk. But so what about your identity motivates you in the context of sex, gender, and intersectionality? You know, we all can be grouped into different personality types. Do you think women, you know, what drives their behavior? Is it because they're more blue, you know, concerned about people and nurturing? Is it because they avoid conflict? Many women could be principled, thoughtful, methodical. Some of us, I think probably me, are more goal-oriented and competitive, you know, value effectiveness. And how does our personality and what drives us intersect with our sex and our gender and all the other environmental identity factors around us? And that is what makes each woman special, each woman individual, and points to the inter-individual variability among women, never mind as distinct from men. Now, on to CIHR. Well, I have good news from CIHR, the Canadian Institutes of Health Research. I am very pleased to tell you, sorry about the slides, they're a little jumpy, very pleased to tell you that researchers are paying more attention to sex and gender. So I think we're going to get more answers. Here, you see the last 10 years of competitions for CIHR, and you'll see that the proportion of CIHR applicants saying yes to sex has really skyrocketed, mostly in biomedical, but also for gender or for both. For people who want support in knowing how to incorporate sex and gender, you've probably all, I hope, seen our training modules by now, but we have a new tool. It's called Meet the Methods. You could go on the CIHR website, and people have said, all right, I get it. I know that I have to incorporate sex and gender, but how do I do it? You know, should I be using an ELISA assay? Is that better than a radioimmunoassay for measuring the hormones? So we're really doing a deep dive in the how. We're tackling other issues too, and you'll be pleased to hear that CIHR's investment in women's health specifically, not just sex and gender research, is up 50% in the past 5 years. So you'll see the red arrow in 2015, it was $50 million that CIHR invested that year, and we are up to over $75 million. Some of it was due to the clinical women's mentorship grants, the strategic funds. A lot of it is in the investigator-initiated stream. And of course, you'll notice that maybe we haven't gone up as much as we liked on that last line, training and career support, but announcement, we will be launching a health research training platform program for girls and women's health in January 2021, so please keep your eyes peeled for that. Some people say that with all the attention on sex and gender, we're not paying as much attention to single-sex studies. Here I've just showed you a screenshot. You could read in pink that some peer review committees, we say that single-sex or gender studies may be considered. They do require a rationale. Saying that men don't have ovaries, I think is a reasonable rationale, so I don't think it's so hard to get that through the door, and I wanted to bring that to your attention. But again, I would reinforce that I'm hoping that the message isn't, when we ask you, is sex accounted for or gender accounted for us to stop the progression of knowledge by thinking that they're distinct, but they do interact. So please keep that in mind when you do your research. In fact, the term sex gender has even been proposed, but I'm still hesitant to use that because a lot of the basic scientists are still talking about gender and not sex, and I really think we do have to make them understand. So how can you shape the future? 1, make sure that women are at the helm of decision making. That may be stepping up yourself as a woman to sit around the decision-making table. It may be as a male ally. Women are so dependent on men to sponsor them to step forward. Or it may be in how you can teach women to be leaders, because women as decision makers influence what gets studied. Here you'll see a graph showing in sort of pinkish there that if you have a female principal investigator, she's more likely to take sex and gender into account in the research. So who you are, and this goes the same for other, Black women. If Black women sit at the table, then they're more likely to consider racism and intersectionality in the research that they do, and there's some good data around that. Number 2, acknowledge that one size fits all is no longer okay. This is a great ad from the Netherlands, Treat Me Like a Lady. And you could just look at the women here, look at the diverse women, how they look, their sexual orientation, their ages, their backgrounds. One size approach, never mind women are not small men, but even for each woman is no longer okay. And intersectional methods really means engaging diverse women at all stages of the research process. Who has those power imbalances? Whose voice hasn't been heard? Right at the beginning of research, make sure that we include them, that we include those voices in the methods design team. Sometimes you'll be able to collect data quantitatively, but probably mixed methods and qualitative approaches are going to be needed in order to engage communities, oversample individuals whose experiences should be accounted for as part of women's health research. And of course, there's many different ways of analyzing either quantitative data with stratification, disaggregate the data, effect modification, or by exploring the narratives. But this is the new, I would say, standard for doing women's health research, in my view. And then, of course, once you've generated the knowledge, how do you apply it into practice? And I think those of you who do clinical research, those of you who are clinicians, those of you who work with clinicians, we need to start teaching cognitive steps for approaching women differently when they're sitting in their blue gown in the emergency room. And the first, of course, is identity recognition. Sex, biologic sex, but also gender identity. And what about the sex differences and clinical manifestations of disease? Women may experience heart disease differently, not with crushing chest pain, but maybe with more fatigue, recognize potential limitations in diagnostic testing and different lab thresholds, the anemia threshold, low blood count may be different for men and women, and when available, ask, does this woman need a different dose of medication based on sex-specific evidence? And finally, that gender bias and diagnosis and treatment that I talked to you back at the beginning of this talk, do you remember what it was about? You could put it in the chat. Yeah, it was about autism. Comes out in many aspects of women's care. So here, for instance, was a study where they looked at how fast women got to the catheter lab if they had heart disease, and they found out that, of course, men, got to the cath lab, what is that, 112 minutes minus 4, 8 minutes slower than men. That, guideline therapy was adhered to more for men when they had an ST elevation MI, which is a type of myocardial infarction or heart attack. And of course, at 30 days, women had 6% higher mortality. But when they intervened and they put in place a protocol that eliminated all gender bias, and I won't go through it with you, but it was a 4-step protocol that always, for instance, put in a radial approach because women have that's the easiest way to access vascular access for women, so we didn't struggle with other access. When everyone got the same therapy, regardless if they were a woman or a man, we increased the door to balloon time. So from the moment you show up to the moment you get your balloon to open up your artery in your heart, to almost the same amount of time for women and men, and we cut mortality in half. Third thing you could do is take a holistic identity approach to women's health, including all the different factors that composes a woman's identity. In your research, you might need to embrace transdisciplinary team science. I talked a lot about non-biological variables. Maybe you weren't trained in that. Why not add a social or behavioral scientist to your team, or an anthropologist or a psychologist? Let's start treating women more holistically, not only in clinic, but also in our research. And promote open science. Do you share your clinical data from women's health clinics? Do you share your research data? We will learn more when we start being more transparent about the data that we have, comparing different health system models for women and finding out what works. And finally, break down stereotypes. Language is so important. Women being hysterical, of course. You know where the word hysterical comes from? Put it in the chat. Right, the word hysterix, which means uterus, which obviously, if we say a woman's being hysterical, that's why she's crying in the emergency room, you know, that really invalidates a lot of what we feel. Even paying attention to language around partners versus are you a wife, or do you have a husband, do you have a partner? Attention to language, empowering language, really changes, as we know, the dynamic of how we respectfully treat women for their health. And so I invite you to contribute to the paradigm shift that I believe is warranted for women's health research, from bikini medicine all the way to identity recognition and respect. To recap, what I want you to do is ensure that women are at the table making decisions about girls' and women's health. I want you to pay attention to language and call out people who don't. Be sensitive to body parts research. We need to do it, but not at the expense of more identity-based holistic research. And finally, adopt cutting-edge research methods on sex, gender, and intersectionality to make sure that we deliver holistic identity, evidence-based research and wellness care for girls and women. I invite you to be bold. I invite you to push the boundaries. Be the leaders others will follow, and women and girls will thank you. Thank you.